No. Maybe, yeah.
A very good evening, everyone. I, Ravisha Rena, on behalf of Mankind Pharma, would like to take this opportunity to welcome all our esteemed delegates who have joined today us on our live webinar on osteoblasts too lazy or just insulin resistant. At the same time, I would like to take this opportunity to welcome our very eminent speakers of the evening. So I would like to take this opportunity to take you through the journey of Mankind Pharma in pharmaceutical industry so far. Mankind Pharma last year completed 25 years in Indian pharmaceutical industry, and our vision is to become the most admired Indian pharma company. Mankind has the philosophy of serving life, and we have always lived up to our values and our name, that is Mankind. We take this opportunity to salute the frontline warriors who have helped the nation to come out of the pandemic. And as a token of appreciation to that, Mankind Pharma's every employee has contributed its 1 day salary in Prime Minister Fund. Talking about Mankind Pharma, we are ranked #1 as per prescription, and we are ranked 4th as per value. Mankind has got its presence in 34 countries, and we have 19 world-class manufacturing units. The three basic pillars of Mankind are quality, affordability, and reach. Mankind has been successfully able to establish its presence in various therapeutic areas, starting from anti-diabetic to urologicals, and has gained leadership in many. Mankind has a well-dedicated research and development capabilities where our major focus is on new drug delivery, active pharmaceutical ingredient, and biosimilars as well. I would just like to end by welcoming all our esteemed delegates and would like to extend a very warm thank you for continuous support from the medical fraternity and encouragement to us. Also, I would like now to hand over the session to Dr. Prashant. Dr. Prashant, over to you.
Thank you, Ravisha, and thank you all the esteemed audience who have joined us here in today's session. Now it is my privilege to introduce you to our eminent speaker for this evening. Professor S.K. Singh, sir, welcome. He is the head Department of Endocrinology and Metabolism at Institute of Medical Sciences, Banaras Hindu University, Varanasi. He has done DM Endocrinology in 1988 from IMS BHU, and he has been former president, vice president, and secretary of Endocrine Society of India. He was president of ESI in 2017, and he has been professor of endocrinology since 2003. He has fellowships in INSA and European Commissions. He has more than 160 publications to his name and 75 international and 86 national publications. He has been principal investigator for various ICMR and UGC projects. Welcome, sir. Now let me introduce you Dr. Kamini Rao, ma'am. Dr. Rao is one of the country's most reputable names in the sphere of assisted reproduction and high-risk obstetrics. She has been a recipient of Padma Shri in 2014 for her distinguished contribution in obstetrics. Dr. Rao has a distinguished clinical and research career in reproductive medicine, where her creative energy, diversity, and versatility are well recognized by the country's entire medical and research community. The pioneering role that Dr. Rao has played in the field of assisted reproduction has resulted from vast research and credible achievement through dedicated service, bringing infinite joy to all infertile couples. Besides, her passion for filmmaking has led to the launch of Purvi Productions, explicitly to create socially encouraging and women-centric films. Her show, Dr. Kamini Rao's Masterclass, is a massive success amongst the viewers, not just across India, but globally. Welcome, ma'am.
Thank you.
Now, let me introduce you to our third speaker of this evening, Dr. Rajesh Navalkar, sir. He's a chief and joint replacement surgeon at Jaslok Hospital and Research Center, Mumbai. He has more than 30 years of experience in joint replacement surgery. He did his joint replacement fellowship from the Rothschild University Hospital, Haifa, Israel. Efficiently handles the complicated type of knee replacement surgeries, joint pain, joint mobilization, knee pain, wrist pain, spinal surgery disorders, neurological problems, joint and muscle problems, muscle weakness, limited motion, and swelling. Under his credit, there are numerous national and international publications. He is actively invited as a guest speaker in scientific meetings, CMEs, and worldwide conferences to talk about various joint replacement surgeries. Welcome to you too, sir. Now, with this, I welcome all three speakers and hand over this session to our first speaker, Professor S.K. Singh, sir.
Thank you, Dr. Prashant. And first of all, I thank this uh, Pharma Mankind for giving this opportunity to share the webinar podium with stalwarts, Dr. Rajesh and Dr. Kamini. It's a great privilege to talk in this webinar and to talk at first on calcium metabolism and diabetes. As I said that it is little difficult topic for me to discuss when everybody talks about vitamin D and diabetes, and importance of vitamin D in fact steals away our attention from calcium, which is very important. And in fact, vitamin D helps in absorption of calcium. So the basic the challenge would be addressing the problem of calcium, but then there are so many contenders which are supporting the absorption of calcium, and therefore I think this is very important to talk little about the calcium metabolism first, and then we have to discuss the importance of vitamin D and in the skeletal health. So the other two speakers would be talking about. I will take you through the calcium metabolism next 20 minutes. And please bear with me regarding the some basic deliberations of the calcium metabolism. When we talk about metabolism, usually this is not very favorite area for most of the clinicians, but then we have to know, because we cannot ignore the basic fundamental uh, principles of medicine. So diabetes, a global epidemic. We all know. I have not shown those slides which are showing the staggering figure of very high prevalence of diabetes in rest of the world, including our own country. So this is the diabetes prevalence by age and sex in 2019, and this atlas actually showing that the diabetes prevalence is increasing with advancing age, and the majority of people are in the age range of 50 to 80, and that is the time when most of them are also having the problem of bone health. So it is quite possible that we'll be having a problem of bone disease, osteoporosis or metabolic bone disease, along with diabetes occurring together. And therefore, we have to understand if there is any link between the two, and if treatment of one is going to help the other, or the other way. So this is what the purpose of the present talk on the calcium and the calcium and diabetes. We all know that India position is number 2 right now in year 2019, and it is projected that we perhaps would be overstepping or will be overtaking China in years to come. Uh, Coming to the mineral important for normal metabolism, we all know that the calcium is very important, is one of the very important element mineral in our body. It is for building strong bones and teeth, helps in clotting blood. It has effect on the clotting factors, dilatation of the blood vessels, and sending and receiving the signals. So it's acting as a neurotransmitters, movement is squeezing and relaxing of the muscles, releasing hormones from the organs, hormone endocrine organs, keeping a normal heartbeat, sending signals inside the human body cells from brain. So it is also helping in communication in our body. The calcium and type 2 diabetes, there are some indirect evidences that the calcium is also playing significant role, as the study has mainly focused on the vitamin D and calcium. But we know that vitamin D, calcium homeostasis are linked together, and they have also been identified in patients with diabetes. So there is accumulating evidence to suggest that altered calcium and vitamin D homeostasis may play a role in the development of type 2 diabetes, particularly vitamin D, and then consequent upon that, the calcium might also be playing a role. Calcium homeostasis plays a major role in insulin resistance, and there are some studies, there are some evidences supporting to that fact. It is impaired in diabetes and contributes to defective cell regulation in erythrocyte, cardiac muscles, platelet, and skeletal muscles. Impaired homeostasis is concerning, as it could be significant contributing factor in regulation of proper insulin secretion and its action, also affecting the various vascular complication independently a person has diabetes and calcium deficiency. The role of calcium in signaling in pancreatic cells, it helps in cell proliferation. Calcium is also responsible for cell survival. So this has a role in cellular apoptosis. Calcium oscillations for proper cell function, as we have already seen that it helps in signal communication, calcium in biphasic insulin secretion, calcium on subcellular level. You might recall that there is a biphasic insulin secretion, the first phase and the second phase. First phase is of short duration, second phase is of long duration. And both the first and second phase are actually dependent on intracellular calcium inside the beta cell. So it has a very pivotal role in insulin secretion. This cartoon is actually showing how the calcium is playing its significant role in the beta cells. And you can see the calcium in the endoplasmic reticulum is stored, and it is released from there. And through a cascade of events occurring inside the mitochondria, the calcium helps uh, in generation of ATP that actually blocks the potassium channel. So if there is a increased ATP inside the beta cell, the potassium channels are blocked and potassium level inside the cell is increased. To counteract it, there is a influx of calcium inside the beta cell, and because of the depolarization of the cell membrane, and this influx actually helps in release of insulin from the insulin vesicles stored inside the beta cell. In vivo, calcium regulation is also playing role in the muscle contraction that we all know from the basic knowledge of physiology. So calcium plays important role in muscle contraction. Now, calcium is released and through my mitochondria, and it helps in actin myosin complex formation. Now, when the intracellular calcium is reduced, you can you can guess there would be a problem in muscle contraction, and this is what happening in the patients with diabetes, that there might be reduction in the intracellular calcium and also extracellular calcium, and that will be reflected in the reduced muscle contraction. The literature are depicting interrelationship between calcium and diabetes, though they may not be directly linked. For example, the studies have shown that women taking calcium more than 1200 milligram per day had lower prevalence of diabetes than those who were taking less than 600 milligram. So this was one paper in 2007, and subsequently there are many more papers which have come up showing this interrelationship, and also the role of vitamin D along with the calcium in development of diabetes. They have a significant impact on the insulin resistance. So if there is a vitamin D deficiency and also relative calcium deficiency, there would be problem of insulin resistance. The mechanisms, this cartoon is showing the mechanisms of the basically the calcium and vitamin D in patients with diabetes. The improvement in pancreatic beta cell function, direct effect of vitamin D on insulin secretion. We have some we have some evidence to demonstrate that there are receptors on the beta cells for vitamin D, and therefore if there are receptors, it means it has some physiological role, and vitamin D perhaps is playing role in, at least in, differentiation of the beta cells. So beta cell population is dependent on the good amount of vitamin D, and we have already learned that the calcium is playing role in beta cell action. So beta cell population as well as its action is dependent on calcium and vitamin D. Indirect effect of vitamin D on insulin secretion, again, it is through calcium. So it is not a direct effect. Calcium effect on insulin secretion, that we have already learned. Intracellular calcium has significant impact on the insulin release. Improvement in insulin action, a direct effect of vitamin D on insulin action. And there have been some study, though they are sporadic and they have not been they are not too many to demonstrate, but then vitamin D directly activates PPR gamma, a transcription factor implicated in regulation of fatty PPRA delta in the fatty acid metabolism. Indirect effect of vitamin D on insulin action. Vitamin D contributes to normalization of extracellular calcium, ensuring normal calcium influx through cell membrane and adequate calcium pool intracellularly. Calcium effect on insulin action. This is also shown in the studies that calcium has a permissive effect on insulin action on the tissues. So impairment of insulin receptor phosphorylation is dependent on calcium. So if there is a calcium deficiency, there could be a problem of receptor phosphorylation, which is a prerequisite for intracellular insulin action and the and glucose metabolism. Improvement in systemic inflammation and effect of vitamin D on cytokines. There are n number of papers showing that vitamin D is important in regulating the cytokines. In fact, our own study from my department, I had interest in working on vitamin D and diabetic foot infection, and we have shown that the inflammatory cytokines are dysregulated in patients with diabetes. And this regulation is dependent on vitamin D level. And through that paper published in BGN, British Journal of Nutrition, we showed that the vitamin D level less than 10 nanogram may have effect on cytokines. Less than 20 may have a calcium homeostasis effect, or less than 30 may have the bone effect, but less than 10 has a definite effect on the cytokines and immunological effect. Therefore, through that paper and through many papers, it has been established that vitamin D is perhaps acting through cytokines, and the cytokines play a significant role in causing chronic inflammation that becomes one of the concern for development of large vessel disease in diabetes. We know that people having high inflammatory markers have more coronary artery disease and short survival. There are papers showing effects of combined calcium and vitamin D supplementation on insulin secretion, insulin sensitivity, and beta cell function in multi-ethnic vitamin D deficient adults at risk for diabetes. And this was a pilot study, and the conclusion of the study was that in fact they could not demonstrate the improvement in the GTT or the overall beta cell function in diabetic patients, but they have speculated that pre-diabetic patients, if they are supplemented with calcium and vitamin D, there would be improvement in insulin sensitivity through this paper. So I think there is a scope to study the supplementation of vitamin D and calcium together in patients who are impending to develop type 2 diabetes, and some data are more appearing in literature, and perhaps we'll have more definite evidence in time to come. This is showing that mean serum 25 hydroxy D concentration at baseline 2 and 4, 6 months after calcium vitamin D treatment. Definitely you will have increase in 25 level with supplementation of vitamin D and calcium. And the dietary calcium, magnesium, major food sources and risk of diabetes in US black women. This paper has suggested that women who used calcium supplementation had lower risk of type 2 diabetes than non-users. And it was a multivariate adjusted hazard ratio of 0.82, which is significant less than 1, is quite significant, 0.82. Magnesium, zinc, and calcium, vitamin D co-supplementation improves glycemic control and markers of cardiometabolic risk in gestational diabetes. So if you maintain these levels in gestational, you are going to have better glycemic control. And this is the paper which is showing published in the year 2018 on applied physiology and nutrition and metabolism. Insulin sensitivity increase after calcium supplementation and change in intraplatelet calcium sodium hydrogen exchange in hypertensive patients. Patients with hypertension diabetes who receive good amount of calcium have shown improvement in insulin sensitivity and also sodium hydrogen exchange, because sodium hydrogen exchange is suppressed by the intracellular calcium. So they have a more vasodilatory response, and that has been shown in these papers. The effect of calcium and vitamin D supplementation on blood glucose and markers of inflammation, which I talked earlier, that vitamin D uh, improves the inflammatory markers, particularly cytokines, and the combination of vitamin D and calcium would definitely show benefit in reduction in the cytokine, inflammatory cytokines. Effect of combined calcium and vitamin D supplementation on fasting plasma glucose and HOMA insulin resistance in subgroup. As you can see, that patients with impaired fasting glucose had reduction in the fasting blood glucose, and also the HOMA insulin resistance in the B picture is showing that there was a marked reduction. It was a statistically significant reduction in HOMA insulin resistance and the fasting blood glucose with supplementation of vitamin D and calcium. This is another paper showing a link between serum calcium insulin resistance with hypertension. And in this study, actually, these were not diabetic patients, but they have shown that those who had a good amount of calcium in circulation actually had responded well to treatment. And therefore, what we said, the sodium hydrogen exchanger is dependent on the calcium, and that has been shown in the other study. So summary of this trial was the in present large prospective cohort study, conjoint effect of serum calcium insulin resistance on the development of hypertension were observed, and evidence that increased serum calcium concentration precedes peripheral insulin resistance was found. Uh, it means that we started getting more and more information as we looked at this aspect of adequate calcium intake and its effect on insulin resistance and the consequences of insulin resistance. As you know, there will be development of metabolic syndrome and hypertension being part of the metabolic syndrome. So evidence-based observation from several studies showed a moderately consistent association between low vitamin D status and calcium or dietary intake and prevalence of diabetes. Outcome revealed an inverse association with incidence of diabetes or metabolic syndrome for the highest versus lowest combined vitamin D calcium intake. Hyperglycemia produced an adverse influence with vitamin D and calcium deficiency. So if you have a vitamin D calcium deficiency and develop diabetes, you will have further worsening of these, and that will be a kind of vicious cycle without exit unless intervention is done. Another cross-sectional study was performed in 40 patients with type 2 on healthy controls to evaluate serum level of calcium and A1C. The result showed that diabetic group with increased A1C experienced a substantial decrease in serum calcium compared with the control group and normal. So those who develop diabetes and very severe hyperglycemia will have somehow adverse effect on the calcium homeostasis, and their calcium level will be on lower side. And this could be linked with the uh, mm, polyuria, loss of solute in urine, and also loss of mineral and calcium excretion may be enhanced. One cohort study demonstrated an elevated risk of diabetes in individuals with increased serum calcium concentration. Now, this is another area which showed that if the calcium, sorry, yeah, the showed overall increase in serum calcium level during follow-up. So those who are having more calcium or hypercalcemia will also have a problem uh, for diabetes. So both the situations, low calcium and hypercalcemia, will have impact on this and therefore needs to be normalized. The study have shown a complex association between calcium level and pathogenesis of diabetes. Decreased beta cell function was related to abnormal calcium regulation, which could further connect to altered glucose homeostasis and oxidatory stress. Cell culture study showed that high cytosolic calcium levels
Sir,
may be
sorry to
associated
disturb
with
you.
insulin stress.
Sir, your slides are out of slideshow actually. So can you just resume the slideshow, sir?
Okay, right. You're not seeing the slides?
No, sir, no, not yet.
Okay, just a minute. I don't know how it happened. Now you can see it?
Yes, sir. Yes, sir. Now it is good.
Right. So I think this was the uh, last slide. A calcium deficiency has been associated with type 2 and high blood pressure, impaired pancreatic beta cell function, insulin resistance, low-grade systemic inflammation are important risk factors for developing diabetes and also for developing diabetic complications. Altered calcium homeostasis may contribute to insulin secretion, beta cell function, and in older individuals with impaired fasting glucose combined with calcium vitamin D at, supplementation might improve some of the glycemic sequelae or glycemic problems in patients with diabetes. I think this is what I wanted to pass it on. But the punchline again, I would say that more data are there with vitamin D, and somehow the role of calcium directly causing comorbidity with diabetes has been largely overlooked. Perhaps the reason being that when they talk about vitamin D, they think that ensuring the adequate amount of vitamin D will have adequate amount of calcium in our body. But then those who are not taking adequate calcium and only consuming good amount of vitamin D again will not have the benefit of both calcium and vitamin D supplementation. So that is the important point I wanted to make. Thank you very much for your kind attention.
Thank you, sir. Thank you for this enlightening talk, sir. Now, without taking any much time, I request Dr. Kamini ma'am to please share her slides.
Yeah, thank you very much for inviting me on this show, Mankind Pharma, and of course Prashant. And I would like to be talking to you on vitamin D deficiency and prevention in women. I'm sure all of you know, and our first speaker has spoken elaborately on the calcium metabolism. And so, can we have the next slide, please? Okay, can you get all these pictures of? Yeah. Yes. There has been widespread nutritional deficiency, and yet it's the most underdiagnosed and undertreated nutritional deficiency in the world. This is the sunshine vitamin. India, though, is a tropical country and has adequate sunshine, yet the prevalence of vitamin D deficiency is high in India. I wonder why, because the actual vitamin D, the cost is very less. We have plenty of sunshine, but still we are deficient. So let's look why. Next slide. The high prevalence of 25-hydroxy vitamin D deficiency in the apparently healthy Indian population. There was a study of over 26,000 apparently healthy individuals enrolled under executive health checkup at the Medanta, the Medicity, Gurgaon. The total prevalence of this vitamin D deficiency was over 93%. And of these, 34% had vitamin D insufficiency and 59% had frank deficiency. Vitamin D deficiency was 60% in males and 55% in women. Vitamin D insufficiency was 34% in males and 35% in females. Next. The high prevalence of vitamin D deficiency in postmenopausal women is to be expected. So in apparently healthy Indian postmenopausal women, we see over half had vitamin D deficiency, about a fifth had insufficiency, and another quarter had inadequate or adequate vitamin D levels. So which means to say that only a quarter of the population of postmenopausal women really have adequate vitamin D levels. High prevalence of vitamin D deficiency exists among apparently healthy Indian postmenopausal women. Next. So the serum vitamin D cutoffs indicative of vitamin D deficiency and insufficiency or sufficiency. If you look at the serum value of vitamin D and the status of vitamin D, deficiency would be less than 20 nanograms per ml, insufficiency would be between 21 to 29, and the sufficiency would be over 30, and toxicity would be over 150. So between sufficiency and toxicity, there is a wide gap. So if we look at women, most of them fall into the category of insufficiency of 21 to 29. So even if we say that we are quite okay, we don't have any bone pains, and we are all right, even in the age group of say 20 to 30, you'll find quite a lot of them would be in the insufficient group. Next slide. So how does this vitamin D metabolism occur? There is sunlight, and then it works on the skin. Then that is converted to 7-deoxycholesterol, then cholecalciferol, that is vitamin D3, and then you have the dietary intake of vitamin D3, that is either fish and meat, and then the vitamin D2, which is again from food supplements. Then it goes to the liver. Then from the liver, it gets converted into 25 hydroxyvitamin D3, goes to the kidney, and 1 to 5 dihydroxyvitamin D3. Now, this is extremely important as we look at it. This metabolism is what is being followed with the vitamin D. Next slide. So when we talk about vitamin D deficiency, why is it that with a tropical country like India, and we have so many people in the farming community, the working community, a large number of people who actually spend their time outside, have vitamin D deficiency, but the lot of white-collared staff are still spending a lot of time in the AC rooms. So increased indoor lifestyle, preventing adequate sun exposure, since most Indians are vegetarian and vitamin D rich dietary sources are limited and unaffordable to the socio-economically underprivileged populations. Therefore, sun exposure is the only major source of vitamin D. High pollution levels, phytates and phosphates in fiber-rich diets can deplete vitamin D stores and increase calcium requirement, increase skin pigmentation, use of sunscreens, changing food habits, low dietary calcium and vitamin D intake, cultural and traditional habits, and repeated and unplanned, unspaced pregnancies in dietary deficient patients can further worsen vitamin D deficiencies. Next slide. Of course, we must look at the skeletal and extraskeletal manifestations of vitamin D deficiency. We do have the skeletal, which is the osteomalacia and osteoporosis in adults, and because of the inadequate dietary intake of vitamin D and poor absorption of calcium from the diet and increased calcium resorption from the bone and kidney, and reduces bone mineral density, resulting in osteoporosis and osteomalacia, muscle weakness, and increased risk of falls. Whether the fall caused the fracture or the fracture caused the fall is a debate that still goes on. It can also cause depression, Parkinson's, Increased risk of suicide. Imagine vitamin D causing suicide deficiency, that is, infectious diseases, TB, viral upper respiratory tract infections such as influenza, autoimmune disorders like the rheumatoid arthritis, cancers such as lung, breast, colorectal, prostate, and ovary, pancreas, and esophagus. Increased risk of heart disease, type 2 diabetes, and insulin resistance and obesity. Next slide. So women experience menopausal bone loss in addition to age-related bone loss. So bone loss starts from the age of about 30 to 40 years in both men and women. The rapid bone loss may occur during menopausal transition, and in women, menopause is followed by an immediate decrease in bone mass and density within a year. This increased rate of bone loss reaches equilibrium about 10 years post-menopause. Continuous age-related loss. Adequate precautions must be taken during menopausal years to prevent osteoporosis during later years, as age-related bone loss is a continuous process throughout life, and therefore what you do put in at the age of 30 or age of 25 to 30 as a fixed deposit, you will reap the rewards throughout your postmenopausal years. So my dear friends, do not just think that after you reach menopause, you start having the supplementation. Start the supplementations much before. Next slide. So vitamin D is an important for the skeletal health and in mineral metabolism. Its direct action on osteoblasts and osteoclasts and interaction with non-skeletal tissues help in maintaining a balance between bone turnover and bone growth. Low vitamin D is associated with impaired calcium absorption, a negative calcium balance, and a compensatory rise in parathyroid hormone and excessive bone resorption results. Bone resorption exceeds bone formation after menopause. So this imbalance of bone remodeling and a rapid net bone loss, and this could be due to the estrogen deficiency, increases the number of osteoclasts and decreases the number of osteoblasts, resulting in an overall bone resorption. Studies indicate that the osteoporosis and osteopenia or low mass bone mass may occur at a relatively younger age in the Indian population. Next slide. Next slide. So, how is vitamin D and osteoporosis related? Major public health problem in Indian women. Osteoporosis is characterized by low bone mass, microarchitectural disruption, and increased skeletal fragility, decreased bone strength, and increased risk of fracture. Regarded as a silent disease until systemic pain, spine deformation, height reduction, and or fragility and fractures occur. Factors contributing to high prevalence is low calcium intake, vitamin D deficiency, increasing longevity, sex inequality, early menopause, genetic predisposition, lack of diagnostic facilities, general lack of knowledge about bone health. Next slide. So therefore, what would be the impact of osteoporosis would of course be fractures following minimal trauma, especially the vertebrae are the most common and the earliest manifestations of osteoporosis. Fractures are an important cause of morbidity and mortality and occur much earlier in Indians versus the West. Osteoporosis-related fractures are associated with substantial pain, suffering, disability, and possibly even death for the affected patients. Next slide. The prevalence of osteoporosis and fragility fractures in the Indian women have shown that from 8 to 62% of Indian women of different age groups. In this study, Indian women between the age of 30 to 60 years from low-income groups and the femoral neck, almost a third of the women had osteoporosis and half of them had osteopenia, with only a fifth of the women having normal density. At the lumbar spine, the prevalence of osteoporosis is almost to 50%, but with equal numbers having osteopenia and only 14% having normal density. In a study in Delhi of 1,600 healthy subjects over 50 years, a half of the women had osteoporosis versus a quarter of the males. About 50% of women had osteopenia versus 50% of the males. So, next slide. The prevalence, of course, going forward, the prevalence of vertebral fractures in women over 50 years was about 17%. Prevalence of vertebral fractures increased with age in females from 14% in 50 to 59 years to approximately 22% in those over 70 years, but not in men. Hip fractures have been reported to be 159 in 100,000 women older than 50 years in Rohtak district, Haryana. Next slide. So the risk factors for osteoporosis in Indian women, the non-modifiable risk factors, that is the female sex, advancing age, ethnicity, and genetic factors. So this cannot be modified. But what would be the modified factors are calcium intake. The low calcium intake through dairy products and non-dairy sources, poor consumption of dairy products, unequal distribution of milk and milk products, with boys and men being served larger portions, especially in the lower socioeconomic group, higher ratio of phytates to calcium in Indian diets, especially among the rural Indians, phytates and oxalates in the fiber-rich Indian diet reduces calcium absorption from the already calcium-deficient diets. Next slide. Vitamin D intake, and India has abundant sunlight, yet vitamin D deficiency is highly prevalent. The reason being that low sun exposure, traditionally clothing, saris, salwar kameezes, inadequate dietary intake, poor vitamin D fortification of food, and highly pigmented skin are all reasons why there is a deficiency of vitamin D. Vitamin D deficiency inhibits calcium absorption from the gut, which in turn affects the mineralization of bone. So poor nutritional status, that body weight of less than 60 kilos and height of less than 155 centimeters may significantly increase the risk of osteoporosis in women. What about the lifestyle? Urbanization, sedentary lifestyle, decreased sun exposure, lack of exercise, and cigarette smoking. Medication use, long-term use of glucocorticoids, that is steroids, also causes osteoporosis. So one has to look at it very seriously. Even those on immunosuppressants have this risk of osteoporosis. Previous history of fractures, again, predisposes to more fractures. Next slide. Now comes the big syndrome of polycystic ovarian disease with vitamin D. The prevalence of vitamin D deficiency of less than 20 nanograms per ml in women with polycystic ovarian syndrome is almost 2/3 to 85%. Many observational studies suggest an inverse association between vitamin D status and metabolic disturbances in PCOS. Low 25 hydroxy vitamin D levels may exacerbate the symptoms of PCOS, including insulin resistance, ovulatory, menstrual irregularities, infertility, hyperandrogenism, obesity, and increase the risk of cardiovascular diseases. Women with PCOS and a severe vitamin D deficiency had the lowest levels of the HDL cholesterol and the apolipoprotein A1. Genes involved in vitamin D metabolism have been suggested as candidate genes for the susceptibility to PCOS. A few polymorphisms in the VDR gene such as the CDX2, the TAC1, the BSM1, the APA1, and the FOC1 influence insulin secretion and sensitivity in women with PCOS. Next slide. Therefore, if you look at this, vitamin D plus calcium plus metformin improves menstrual irregularities and ovulation in PCOS. So if you were looking at about 60 infertile PCOS patients were treated with, in group 1, oral calcium of 1000 milligrams per day plus vitamin D of 400 international units. The group 2 was calcium of 1000 milligrams per day plus vitamin D of 400 international units plus metformin of 1500 milligrams per day, and group 3, that is metformin of 1500 milligrams per day only. The number of dominant follicles of more than 14 millimeters during the 2 to 3 months of follow-up was higher in the calcium, vitamin D, and metformin group, and that is group 1, versus either of the other 2 groups. So vitamin D should be considered as part of the treatment of PCOS. Vitamin D supplementation reduces insulin resistance, hyperandrogenism, and improves lipid metabolism in women with PCOS. So therefore, the practice point would be that women with PCOS should be screened for vitamin D deficiency, and where supplementation is required should be given. Next slide. Now, this is another interesting phase, and that is the endometriosis and vitamin D. In fact, vitamin D is now getting into every realm of disease in the woman, and therefore vitamin D becomes integral to women, and vitamin D has to be supplemented with all women. Vitamin D has been shown to have an immunomodulatory, anti-inflammatory, and anti-proliferative effects. Significant pain reduction has been observed with vitamin D supplementation in women with primary dysmenorrhea. Low vitamin D levels are associated with onset of severity of endometriosis. There was an observational study of 49 women with singleton ovarian endometrioma. So if we were to look at the mean of 25 hydroxy D3 serum levels was 22, and 42 were diagnosed with hypovitaminosis D. Women with the lowest vitamin D levels also had the largest ovarian endometrioma, interesting, or ovarian cysts. In the hypervitaminosis D, women, the mean standard deviation diameter of the ovarian endometrioma was 40 plus minus 22.6 millimeters, while in the normal vitamin D serum levels, women, it was 26 plus minus 12, which was significant. Next slide. Now let's look into the pregnancy and vitamin D. Studies have shown an association between low vitamin D and adverse maternal outcomes, that is, pregnancy-induced hypertension, high blood pressure in diabetic pregnancies, gestational diabetes mellitus, recurrent pregnancy loss, preterm delivery, primary cesarean section, and postpartum depression. Maternal vitamin D deficiency has detrimental effect on bone mineral accrual by the fetus, leading to reduced bone mass at birth and in childhood. Neonatal vitamin D stores are completely reliant on maternal supply. Thus, poor maternal vitamin D status during pregnancy is a major risk factor for neonatal rickets. So what would our practice points be here? Infants are wholly dependent on their mother for their vitamin D status. Pregnant women should have enough vitamin D at the time of delivery to ensure sufficient vitamin D levels in their baby for the first 4 to 6 months. All women, therefore, should be offered testing for vitamin D status and in early pregnancy, and recommended supplementation would be 200 to 400 international units if found deficient. So pregnant women with a serum level of less than 30, nanograms per ml are considered to be in this deficient. So therefore, they need to be supplemented. Next slide. So what about cancer? Now, vitamin D has entered into the realms of cancer as well. Various studies have shown that the protective effect of vitamin D against ovarian, breast, and colorectal cancers, where low vitamin D3 levels are associated with a higher risk of developing cancers, while vitamin D sufficiency is associated with lower risk of cancer. Vitamin D has been associated with obesity, and up to 20% of cancers have a causal association with obesity. An increase in blood vitamin D levels by 5 nanomoles per liter was associated with a 6% decrease in breast cancer risk as well. Next slide. Now, serum vitamin D levels were significantly lower in cases of newly diagnosed breast cancer patients versus controls, that is 85% to 55%. The adjusted and adjusted odds ratios for breast cancer in cases and controls have shown statistically significantly increased risk of breast cancer with low vitamin D levels. After adjustment for age, parity, BMI, sun exposure, economic status, and educational status, the odds ratio for breast cancer risk was 7.8 for women with vitamin D concentrations of less than 20 nanograms per ml. Next slide. Now, calcitriol inhibits estrogen synthesis and signaling in breast cancer cells. We have calcitriol, the hormone active metabolite of vitamin D, inhibits the growth and induces the differentiation of many malignant cells, including breast cancer cells. Calcitriol exerts its anti-proliferative activity in breast cancer cells by inducing cell cycle arrest and stimulating apoptosis. Calcitriol also inhibits invasion, metastasis, and tumor angiogenesis in experimental models of breast cancer. Calcitriol downregulates the expression of estrogen receptor alpha and thereby attenuates estrogen signaling in breast cancer cells, including the proliferative stimulus provided by the estrogens. So, inhibition of the estrogen synthesis and signaling by the calcitriol and its anti-inflammatory role in the use of calcitriol for the prevention and or treatment of the breast cancer cells. Next. So prevention of vitamin D deficiency, so getting vitamin D through sunlight by exposing 15 to 30% of body surface area, face, neck, and both arms and forearms without sunscreen for at least 30 minutes between 10 a.m. and 3 p.m., depending on the season, latitude, altitude, pollution, and skin pigmentation. Food fortification to increase intake by 30 to 50%. Vitamin D supplements, Calciferol, is the preferred therapy for correction of deficiency and maintenance. Management would be of this deficiency 60,000 units orally once a week for 8 weeks, preferably with milk. One injection of 60,000 international units given to correct the deficiency and not to be repeated before 3 months and may be given after confirmation of persistent low vitamin D levels. Maintenance therapy would be 60,000 international units once a month in summer or twice a month in winter, and vitamin D supplementation of 2,000 international units per day or an injection of polycalciferol of 3 lakh units IM twice a year should be enough. I thank you for your patient hearing.
Thank you so much, ma'am. And now, without wasting any time further, please, I hand over this session to Dr. Rajesh, sir.
Good evening, everybody. Today I'm talking about osteoporosis, which is a gift of longevity. I call it a gift of longevity because it is inevitable You can't do anything about it. So we have to consider is what comes free with longevity is osteoporosis. And we must try to learn how to deal with it. Here you can read the definition of osteoporosis as progressive systemic skeletal disease characteristic, loss of bone mass and destruction of microarchitecture. That's the word health occurs. Next slide, please. Next slide. Yeah. Well, osteoporosis does not pardon any race, religion, or sex. Rather, it is more unkind to our fair part, which is unfair. However, it is inevitable, and we have to learn how to get over it instead of grumbling over it. Next slide, please. Well, many people have habits of classifying anything that they come across. Somebody has classified osteoporosis as primary osteoporosis, that is idiopathic and juvenile. Honestly speaking, I'm an orthopedic surgeon, so I don't see any juvenile osteoporosis at all. Idiopathic and postmenopausal and premenopausal. Okay, next slide. Well, there are various causes of secondary osteoporosis, starting from drugs to chemotherapy, and the basic cause of any osteoporosis is immobility. If you immobilize your hand, you can do an experiment to yourself during my rest of the talk. You just don't move your hand during my rest of the talk, which I assure will be short enough. At the end of the talk, your hand will be stiff. So that's how osteoporosis sets in so fast. Okay, next slide. Characteristics of bone. Now, bone structure is mainly meant for bearing our weight. It is a perfectly elastic structure with a very high modulus of elasticity, and has a structure which can be compared to RCC building, reinforced cement concrete. If you see a reinforced cement concrete building being done, you will see a steel skeleton of a pillar, and thereafter they pour concrete. Similarly, bone is something like RCC, reinforced cement concrete. Protein fibers are the reinforced steel, and the calcium, magnesium, and other minerals is the concrete. So this is in short telling you what is bone architecture. Next slide. Bone density and bone quality. Well, bone density, when I talk of bone density, I always remember one of the great professors of North India, Professor Maini and Dr. Singh. There is an index known as Maini-Singh index. Can I see the slide of Maini-Singh index, please? That's right. Now, this is an X-ray. Before all this bone densitometry came into existence, Dr. Maini and Singh from North India, they found out a very simple and economical method of judging bone density by doing an AP X-ray of the hip. Now, as you see on this X-ray, there are different trabeculae which are classified into primary tensile, primary compressive, secondary tensile, etc. As the osteoporosis progresses, this trabeculae progressively disappear, indicating the severity of osteoporosis. I stand up to this methodology of assessing of osteoporosis in a poor country like India. And I'm deliberately mentioning it because it is something unique, lateral thinking. You must stand up to this. Next slide. Oh, here I deliberately put this X-ray. Many people think that we have two hip joints, so each joint must be taking half our weight. Well, sadly speaking, it's not true. Both the hip joints take the same weight. If you weigh 60 kilo, left hip takes 60 kilo, right hip 60 kilo. It's because of a typical angle of 120 degrees, which is a neck and shaft angle in proximal femur. I am mentioning this because commonest fracture which occurs in an osteoporotic patient is fracture neck femur. I think next to the vertebral fracture. Vertebral fracture came into existence after auto rickshaws were introduced in Mumbai. Auto rickshaws bounce a lot, and they are one of the causative factors of vertebral compression fracture. But fracture neck femur, by and large, is the first thing which tells the patient you are old now. Next slide. Okay, this is the fracture of the X-ray of the lower end of the radius, which has a cortico-cancellous junction. So cortical density of the bone drops drastically during osteoporosis, while the cortical density remains, as cancellous density diminishes drastically. As a result, there is a weak junction. That cortico-cancellous junction becomes very weak, and a slight fall can cause a fracture. But there has to be a fault. A simple injury cannot introduce a fracture in osteoporosis. Next slide. Next slide. Okay. Primary osteoporosis or age-related osteoporosis biggest problem was fracture neck femur. This was overcome in 1985 by introducing cementless hips. The problem with osteoporosis is there is a cortical bone loss, which is a lot, and there is no proximal cancellous bone for the implant to hold. So the implant keeps moving, and that's a failure of hip replacement. So with the advent of materials and metals, biomedical engineers invented few new designs which are porous coating or hydroxyapatite coating on the proximal portion of the hip implant. They made an extra long implant which will go beyond the isthmus of femur and have a firm hold without cement. And that has changed the whole story. In last 20 years, no osteoporotic patient has been bedridden because of a hip fracture. For that matter, any fracture. Okay. Next. Last but not the least, please do not forget vertebroplasty. Vertebroplasty is a proven procedure, absolutely proven procedure, and renders the patient painless in 15 minutes. Believe me, in 15 minutes. Only thing, you must know how to do it well. I can assure you, any patient with fracture of the spine less than 3 weeks old, but more than 10 days old, can be taken up for vertebroplasty. And the procedure is done under local anesthesia, and patient becomes painless on the table itself. It's an extremely gratifying procedure. And thank you. Thank you.
Thank you, sir. Thank you very much, sir. Sir, if with your permission, Dr. S.K. Singh, sir, you there?
Out of my
Pardon, sir, your voice was breaking, sir.
running out of my battery.
Okay. So there are a few questions, sir, if you allow us, sir.
Please
If
do.
there... Okay. Sir, the first question is that because in India, people are actually taking sufficient sunlight and all, still we are vitamin D deficient. So is there any particular reason, sir?
Are you asking me?
Yes, sir.
Yeah, skin is so much pigmented, the deposition of skin does not allow the penetration of ultraviolet rays.
Okay, sure, sir.
Same is true to our continent. They are also so dark that ultraviolet.
Sir, is there any effect of vitamin D or calcium supplement on frozen shoulder?
No, It has nothing to do.
Okay. So, sir, actually, doctor is asking. I mean, what is the advice from your side for a frozen shoulder?
Mobilization.
Okay.
Only passive physiotherapy.
And sir, in case of osteoporosis, for how long vitamin D supplementation or calcium supplementation can be given, sir?
Prashant, vitamin D is a fat soluble vitamin.
Yes,
Then
sir.
there is a very big gap between the normal and toxic. But just keep on taking vitamin D on their own. So it is really under supervision that we should add vitamin. Same is true. I would talk about calcium. It can cause calcium nephropathy, and some people get neurologically dull. Any neurologist, when they ask this, they ask whether you are taking any calcium supplement. So people overdo their calcium intake. The result, they become sluggish people because of calcium toxicity. It goes very unnoticed in many cases. So I will take it with caution.
Okay. And sir, another question is that, so usually we say that after 40 years of age, male or female, they should start taking calcium. So is it still 40 years or,
I
sir, what
don't
is your opinion?
agree with that. Calcium causes a lot of constipation, and bowel problems of calcium are totally different. We should not just take it, but not the least. What we call normal values have been stabilized by Western world. We have not done a double-blind study on 25,000 Indian urine rate, etc., and food habits. These are not our factory settings. Yeah. These are not our factory settings. This is what university and Western people have done. Our people do not have such a data, whereby we can see our uric acid should be or vitamin D3 should be. We must do proper 25,000 people data, analyze it, and come to proper statistics. Only then we can talk about our levels. These are not our levels. These are Western world levels.
Thank
All
you,
right.
sir. Thank you, sir. Thank you so much. And thank you, Professor S.K. Singh, sir, and Dr. Kamini, ma'am, so for this wonderful lecture. And I really feel that our audience, who is in the range of around 2,000 doctors across India, have joined us here, sir. And they definitely must have benefited from all the discussions, sir. So, sir, thank you once again. Thank you very much, sir.
For calling us, Prashant. Thank you.
Thank you, sir.
We enjoyed it.
Thank you, sir. Srishti, you there?
Hanji, Dr. Prashant, I'm there.
Okay, so we can end the meeting. Yes.
Yeah.
Dr. S.K. Singh is, can you stop live?
1 second. 1 second.